Good evening, friends. Acute abdomen is one of the most common surgical emergencies, and most students are often asked about what exactly is acute abdomen, what do you do to manage it, and what is the surgeon's perspective in it. So that's what we are going to discuss today. So, first of all, we need to know what is acute abdomen, and then we'll find out what are the various causes, how do you investigate them, and how do you manage them, and finally, how should a surgeon look at it, because there can be even scenarios which are medical, and you may have acute abdomen in a medical condition also, but that won't need a surgical intervention. Well, this is a wonderful quote by Sir Zachary Cope, the same gentleman whose name gets involved in Cope-Swartz test, which you do for appendicitis, where you actually cause the appendix to touch by hyperextension. It is touched by the muscles of the posterior part of the abdomen, and it causes that wincing, that kind of a pain, which actually the patient winces, and that's the Cope-Swartz test. I'm not getting there, but that's the Cope. Sir Cope is of the same fame that I'm referring to. Now, this is a beautiful quote and beautiful statement which also defines acute abdomen. So, if you're asked a question about what is acute abdomen, the general rule can be laid down that majority of severe pains which ensue in patients who have been previously fairly well. It should be a recurring thing, although it can happen in a recurring scenario also. But a person was well in the morning, and certainly it happens, and which last as long as 6 hours, which is usually the time that most less acute pains would disappear, or they may settle down. So if the pain persists for more than 6 hours in somebody who never had any preceding problem, not in the immediate past period, it is usually caused, or they are caused by the conditions of surgical import. So the general rule can be laid down. So what this doesn't necessarily mean true in all the cases. It can be 6.5 hours, pain would have settled and patient can get all right. But usually this is the cutoff. So if you are asked a question as to what is the usual time duration or how do you define it, please remember 6 hours in a previously well patient. That means it is sudden. And if it is persisting, usually this patient should be in the surgical ward and has a surgeon interested. After that, there may or may not be surgery needed. So don't ever say that acute abdomen means surgery all the time. But yes, the time duration of 6 hours becomes quite important. They can be managed by non-surgical methods, and we usually call that as expectant treatment. Now, expectant treatment is a conservative treatment by a surgeon. Expectant means you may expect to intervene. It may happen, like you have expectant mothers, they will deliver at some point of time. You're expecting it to happen. So expectant is something that surgeon is involved in, because any time that surgery is needed, no physician can manage it. So you need to have a surgeon in the loop, and that's the expectant treatment. That is a conservative treatment provided by a surgeon. Now, why is that important? I've just highlighted. This patient should ideally be in the surgical ward, because at any given point of time you may have to operate. Now, to shift this patient from medical ward and to follow it up in a medical ward, it isn't exactly a physician's scenario. Now, what does it actually involve? It often designates symptoms and signs of intra-abdominal disease, usually treated best by surgical operation. So usually best treated, not always. Please pay attention to that. So ideally these patients should be in surgery and should be managed by surgeon. And it's not enough to have a surgical call done and leaving the patient in the medical ward. Evaluation ought to be methodical and timely, which again points towards a surgeon being the treating doctor, because we generally attribute methodical and timely management to a surgeon. Timely decision ensures timely surgery. Therefore, it shouldn't be kept out of sight. We've discussed acute abdomen, intestinal obstruction as a cause of acute abdomen in the last video. So one can make out that all acute abdomens should be treated as some kind of an emergency. Even if you're not operating, you should be prepared to operate anytime. Like I mentioned in intestinal obstruction, never let the sun set twice on intestinal obstruction, which means you should be awake and alert to it. Similarly here, a surgery done late is a wrong decision. Timely is important, therefore. And how would it happen? You do methodical evaluation, and the patient is being managed by a surgeon. And what does the evaluation actually include? A very good history. What does that mean? Since when do you have it? What's the past history? Now, it will obviously vary with each pathology, but by and large, history has to be very detailed. Like, if just to give an example, if you're dealing with a lady who is young and has pain in the right iliac fossa, we know that 80% of appendices that are removed may not, 80% are the cases where you can get appendicitis, but in 20% you may not. And these 20% are usually seen, like in women, you have mitral MERS, which is in the mid-cycle, that is the rupture of ovarian follicle. So you need to take the history of menstruation in details in that lady. Is the pain bilateral, unilateral? Is there any history of discharge to the vagina? Does the patient give you a history of pain, abdomen and collapse, which will indicate a ruptured ectopic? And then you have to corroborate it with, similarly the pain, it's very severe when the patient is lying supine in pancreatitis, but relieved on bending forward, acute pancreatitis. Patient gives you a history of binge, taken lots of alcohol just before the pain happened. Is a known alcoholic, has had pain in the past, you would err on the side of thinking it to be pancreatitis, although it can happen due to many causes. Similarly, pain happening in and around the loin, getting down to the groin and radiating to the testis and penile tip, you would suspect, and if there is an associated burning and micturition, you would suspect it to be related to the ureteric, could be a ureteric colic due to stone. Never say renal colic, because kidney is not a colic is basically a disease involving a tube. If it is blocked, then the peristalsis wave is coming, and with that wave the pain comes. It's a colicky pain, which is classically associated with bradycardia, vomiting, which is non-bilious. And we discussed the acute abdomen, partly in intestinal obstruction also. So by and large, you'll need to take that history. If the patient is lying still in the bed, is not moving, and some people do what is called a Charpoi or the court test, where they shake the Charpoi to see if the patient has pain, which is of course something unethical, and I don't think that's a very useful way to find out. There are easier ways to find it out. So evaluation includes a good history. That's what I wanted to highlight, and it will vary with each condition. Physical findings, that's on examination. If the abdomen is all quiet, there is no tenderness, patient has just a colicky pain, it's likely that it may pass off. But if the colicky pain has shifted into tenderness in a localized area, you suspect that there is some part which is needing attention, where there is a inflammatory process settling in, or some rupture has happened. So it will vary, but you need to pay a good attention to evaluation of the history. Also, a young boy, a teenager, waking up in the middle of the night with a pain around umbilicus, which is then getting localized to the scrotum, you're suspecting torsion in a boy or a teenager. While if it is associated with burning micturition and the pain is persistent, you would suspect it to be due to epidermal orchitis. And the two are differentiated by various methods. I'm just comparing torsion now to epidermal orchitis. Now you have usually the age as a factor. young boys, teen age, middle aged. Associated features referred to umbilicus. Why is it referred to umbilicus? We know that the dermatome for testis is T10. For what else is the dermatome T10? Ovary also. Then also for appendix. So in all these three conditions, in all these conditions, you will have the pain around umbilicus, which is actually a referred pain. Now, what is a referred pain and how do you differentiate it from a local pain? Referred pain is without tenderness. But this is not where the pathology is, so it will be without tenderness. Pain may radiate, then it's following the dermatome all along. But in referred pain, there's pain around umbilicus and there's pain in the testis. Now, when you actually examine these patients, now that history would come handy. Examination, what would you find difference? We have what is called the angel sign. If the spelling is wrong, pardon me. Angel sign is in torsion. You have to understand it's never the torsion of testis, it's the torsion of the cord. Testis doesn't have to turn around. Now, usually say it's the right side, this is the left side. A commonly asked question is which way would the testis undergo torsion? The answer is outwards, like you open a book. So this will be anti-clockwise and this is clockwise. So the answer is this. So therefore, when you are doing the detorsion, you close the book. So you open the book. It will be classically opening of the book here for torsion to happen. And to treat it, close the book. Now, when is it more likely? There are some conditions. One is high investment of tunica vaginalis. This is it. Suppose I take this only. That's tunica. It is high investment. So there is no buttressing. So it can rotate more commonly. What is called as bell clapper testis. Something that you would see on some of the old railway stations, that there is a bell clapper. And also in some primary schools you may find it. So this is high investment of tunica vaginalis. I'm taking a detour so that I can cover certain parts. Prehensile. Brain sign is if you lift I'm repeating, lift the scrotum, the pain is relieved in epidermoorchitis. What I just told you, right? If there is torsion of the cord, like you've seen in swings, the affected testis would lie at a higher level. That is called angel sign. Now this is what would clinically differentiate the two. And then you'll have, of course, the history that I was mentioning. Patient has a history of burning, micturition, or tenderness on DRE in epidermoorchitis because of seminal vesicleitis. So this history would also help. And actually, you will collectively then take a call. Therefore, a detailed history becomes important. I'm just trying to give an example. The other condition I mentioned was Michelmer's, which we'll discuss in detail, but usually young girl, where it'll be the mid-cycle rupture. So what happens is the ovarian follicles rupture, there's some blood that collects, so they may have a classical tenderness also in right iliac fossa, and even rebound because of blood. They may mimic. So Michelmer's is therefore important. Well, I have taken a detour to explain a few points. They will be again repeated so that we can make most of it. Pain is the focal issue. We are talking about acute abdomen, and that's about pain, which has lasted for more than 6 hours in an otherwise fairly well person with no immediately preceding uh, uh, clinical conditions that can be the continuation. And if since it's more than 6 hours not getting relieved, it's of surgical import according to Sir Zachary Cope, which is what I started with. History what should we, now we are taking history first, then we'll take examination. Well, it's a very broad topic, so I'm trying to generally cover all aspects, and in between I'll take detours to explain those minor issues here and there. History should characterize and document the pain as precisely as possible. Now please don't forget documentation. And when you're writing your history as a resident, this is one thing which will actually help anybody. Also make it a point that before you can actually have it seen by a senior person, painkiller should not be given. If the painkiller is to be given, the documentation has to be perfect so that you cannot leave a confusion with the history and the findings and examination. But you need to spend time to have it as clearly documented as possible. I'm not just trying to talk about characterization, I'm talking about documentation, which is important. The duration more than 6 hours or more with increasing intensity suggests surgical operation will be required. Isn't that straightforward? Duration is more than 6 hours and it's getting worse. It's quite likely that you may have to intervene. Therefore, where should this patient be lying? In a surgical ward, not in any other place. If the pain ebbs after a few hours, the probability is low. If the pain ebbs, probability is low. Now, what do you get in a visceral pain? Now, there are various types of pains and very nicely covered here because I would like you to understand it. When your distension happens, inflammation happens, or ischemia happens, the pain is visceral. And visceral pain is not the same as the colicky pain that we talk about. The colicky pain would happen because colicky pain would happen if there is a block to any tube, whichever tube. And if there is a ureteric calculus and patient has vomitings, it's a part of reflex stimulation of the pylorus. And where is this pylorus? Now, if you really look at it, that's the stomach, and you must understand the vagus. Vagus comes in here, gives off an anterior branch, that's a posterior branch. Anterior branch gives off a hepatic branch. You want to supply the liver, as understood, that gives off a pyloric branch. And then it continues down as anterior nerve of Letarget, which gives off parietal branches that supply the P cells, which help in the production of acid, and it ends here as crowfoot. Repeating, that's the left anterior branch that gives off a hepatic branch, which gives off a pyloric branch. Therefore, when you're doing truncal vagotomy, we make sure that we do a drainage procedure because you cut it here. So your pyloric supply is gone, so you need to have a drainage procedure. That's why we need a gastrojejunostomy or a pyloroplasty here. Now the posterior one continues down, it gives off a celiac plexus branch, which is and continues down as posterior nerve of Letarget, which is here. This is anterior nerve of Letarget, and this gives off supply to the P cells. That's why if you're doing highly selective vagotomy, which is cutting these branches, we call it P cell vagotomy. also. And at one point there is a criminal nerve of Grassi which goes up to supply it, which may be missed. So therefore people, that's the criminal nerve of Grassi. This used to escape the parietal vagotomy and there will be recurrence of ulcer. That's in the good old days. Nowadays we have other treatments. So just to explain, the same reason is, the same cause is responsible for the non-bilious vomiting in all colicky pains. So don't be surprised that if somebody has a ureteric calculus or she has a dysmenorrhea due to block in the system, there will be colicky pain and reflex vomiting, which is non-bilious. Now that's a characteristic. So it's not always the antiperistalsis which is responsible for vomiting. That's what you need to understand. Now, so a colicky pain is characteristically with bradycardia and reflux, non-bilious vomiting. So you'll look for that feature. Back to the scenario, parietal pain is sharper and more localized. That's how you differentiate the pain, and you will take that history very carefully. I'm repeating it, pain is a focal issue, and that's what you need to work at. Characterize and document it properly. If it is more than 6 hours and getting worse, probably surgery would be required. But if the pain ebbs after a few hours, probability is low, because it is possible that pain is replaced by tenderness. In that case, the story is that, like I discussed in intestinal obstruction, we are moving towards strangulation. Where the peristalsis drops, the pain disappears, but the tenderness appears. So if there is pain out of proportion to tenderness, it's a colicky pain. Still not ischemic changes. With the tenderness out of proportion to the pain, then you're looking at peritonism or features which have worsened. Either it's perforated because now there is no peristaltic wave because it's leaked, or there is strangulation, which is aperistaltic. Now let's look at each one. The right upper quadrant pain can be due to a whole lot of these conditions. So cholecystitis, classically the pain would be starting in and around the right hypochondrium and radiated to the shoulder or to the back. The radiation to the shoulder is often attributed to the dermatomes, again, irritation of diaphragm, and sometimes it's the same thing as the colicky pain that we talked about. Say, there is a term called as cholecystitic heart. What is that? Because cholecystitis, I just showed you that picture where the hepatic branch gives off a pyloric branch. This is vagus, and this hepatic branch is also going to cover up for the gallbladder. Irritation of this vagus can lead to reflex bradycardia, and patient may have exactly MI-like features, and that MI is basically inferior, so it may be confused with the pain. So be careful about that. And a lot of people therefore want to get an ECG in these patients. But naturally there will be other features, and most importantly there will be no tenderness. If there is tenderness along with bradycardia, cholecystitis, then you're suspecting something wrong with the heart, because cholecystitis will be producing tachycardia. Well, just to give an example, basically, classically the pain is upper abdomen, and that too in the very limited area with radiation to the shoulder. And I've given you the reason for that. The phrenic nerve has the root value of 234, similar to, I'm sorry, 345, which would be therefore covering up for the shoulder and that supraclavicle region. But at the same time, it may be referred to other places, like I mentioned about cholecystitic heart. Then there are other features. I can't get into each individual scenario, but cholecystitis has classically the the Murphy sign, which is on examination. You can actually, at the peak of inspiration, which actually should be the depth of inspiration, but the peak we use the word. The patient holds back as you are palpating in the right hypochondrium, holds the breath, which is due to the inflamed gallbladder touching the peritoneum and you ensuring that it touches it. There is a catch. So that is called Murphy's sign. You also have Boa's sign. Boa is a snake. There is increased sensitivity, so there is hyperesthesia posteriorly, the 9th, 10th, and 11th intercostal space, which is due to the same referred involvement and irritation. So cholecystitis would have other features too. So I'm skipping it because we know about cholecystitis in details. Similarly, it will be hepatitis. There will be other features also. It will be again confined to the right hypochondrium. There may be enlargement of liver. There may be history of prodromal symptoms, which is prodromal symptoms are usually the viremia kind of picture before hepatitis of any kind would have its impact. They could be like malaise, fever, loss of appetite, etc. before it develops. Or hepatitis could be due to other causes also, amoebic hepatitis, where the history of amoebiasis would be there. Amoebic liver abscess could have produced this kind of a picture. So there will be tenderness in the right hypochondrium with other features. So naturally, when we talk about various conditions, they can be discussed in detail. Peptic ulcer disease, classical features, perforated peptic ulcer, it will features of peritonitis, pain in and around the right hypochondrium and epigastrium, and finally there will be features of peritonism on account of the perforation having produced the leakage of contents. Mind you, sometimes the contents go along the paracolic gutter and collect in the right iliac fossa, and they can produce a picture exactly like appendicitis. Many times you opened up for appendicitis, you find appendix is normal and there is a bilious or the upper or the golden yellow kind of contents that have collected here, and you can trace it that they're going right up. It's all mucked up by that time, but it's a possibility and you should not ignore it. Take the history, therefore. I'm repeating again, good at history and documentation of the history are mandatory in order to get a correct diagnosis and not to be surprised, because operative surprise can be really alarming. And of course, there will be other features. There will be tenderness, tachycardia, and the silent abdomen. There will be features of peritonitis, as they call it. Silent abdomen means bowel sounds are reduced or absent. So that would make it quite a situation. Tenderness, tachycardia, silent abdomen, they are features which are important. And peritonitis is classically perforated peptic ulcer will have it. Now, many a times the question is asked, will there be a history of peptic ulcer disease? There may be. But which ulcers perforate, acute ulcers or chronic ulcers? Well, the answer is acute ulcers perforate. So there may not be any preceding history, so don't be confused. Chronic ulcers don't perforate because there is fibrosis in the ulcer, so it doesn't perforate. So where will they perforate? patients where you don't have fibrosis, like immunocompromised individuals or those on steroid therapy, chemotherapy, etc. Otherwise, so will you get a preceding history of peptic ulcer disease? You may not get it. Usually it's an acute ulcer which is just given way. Chronic ulcers don't perforate on account of fibrosis. So they would perforate if there is no fibrosis, which is a defensive mechanism of the immune mechanism. So naturally in an immunocompromised person, that is like HIV or other diabetics, or those on steroid therapy or chemotherapy, I mean, you can make the list longer, but you should understand that chronic ulcers usually would not be perforating. But I'm not saying never. Never say never in surgery. Always is always wrong, and never is never right in surgery. Acute, more likely to perforate. There's no fibrosis. Chronic, less likely to perforate because of fibrosis. But if they're put on immunosuppressants or they are on immunosuppressive drugs, fibrosis may not be adequate, and this may happen. So you look for these features and you look for them very carefully, and that will decide, that will help you make an impression or a diagnosis. So this is necessary, and we must stick to making a diagnosis by taking a very detailed and a good history. Pancreatitis, classically, as I said, may be associated with the features of pain abdomen, which is acute. Patient may give you a preceding history of uh, having taken either alcohol or gallstone, history of gallstone disease. So I'm talking about pancreatitis. You can't discuss pancreatitis. We'll have another talk on pancreatitis, totally focused on it. So presently you concentrate on this. Alcoholic and gallstone pancreatitis. An often asked question is, which is worse? And we jump to an answer. Often it is given in some books also, alcoholic is worse. And that's a wrong answer. It depends on the score. If the score of the patient is good, even if, because I can give you an example, 20-year-old alcoholic getting pancreatitis versus 80-year-old lady getting gallstone pancreatitis. She's not likely to be a good candidate, and she may have a worse outcome than this 20-year-old fellow. So we use what is called acute physiological and chronic health evaluation system. This is 1, 2, and 3. The most commonly used one is 2. Easier to do, and you can read about it. There is an Atlanta score now, and you can get into the details. I'm not going there. But what I'm trying to highlight is, it is the score. We'll discuss pancreatitis in detail at some time, don't worry. Now, it is at some point that we need to, it is some scoring which can help us know as to what is the outcome, rather than just relying on the etiology, because etiology doesn't decide that. Alcohol versus gallstone pancreatitis. But those classical features would be there. You will find pain in epigastrium or around the umbilical region with radiation to back and relieved on stooping. You're looking at this problem. Now, usually the patient will have some kind of a history in the past also, some kind of a pain in the past. So you can actually get some kind of a leaf out of the history. Again, to emphasize, it is important to have a good history. Liver tumors, of course, you'll have more history, gastritis. Now, a word about The peptic ulcer, I'm touching all of them just to keep you alert onto the possibilities. Peptic ulcer disease can be, as they say, it includes gastric and duodenal. Gastric is more likely to change into malignancy. This is almost never, but less likely is a good word. It saves you that trouble. The gastric can be malignancy, but classically pain follows the meal, right? The pain is relieved by meal. Because the whole story here is different. This is a story, they say, of hurry, worry, and curry. The kind of diet you take, the kind of mindset you have, the kind of stresses you take in life, they all contribute. While here, it's the gastric mucosa that has the problem. This is how it is believed. So gastric ulcers and the duodenal ulcers have few things in common. Now we know H. pylori is directly involved, and therefore we do many triples in H. pylori. One is a triple test, which has 3 components, and you can read about it. This is basically the urease test, which is important, and upper GI endoscopy, and you can take a biopsy or you can do what is called a brush smear, etc. Then you have the triple therapy, which you know is of various combinations, one antibiotic, one proton pump inhibitor, and usually one is for the anaerobe. So you can add 2 antibiotics and have again this. And once you have discharged the patient, we do 3 monthly or triple 3 monthly assessment with upper GI endoscopy. So there's few threes with it, just for your consumption. We have therefore some history to take. Now liver abscess is another important aspect that you should look at. When you're looking at liver abscess, classically patient will give you a history of pain in the right hypochondrium with or without jaundice, etc. We know broadly it is amoebic or it is pyogenic. Amoebic is usually solitary, may not be, and this is multiple because their mode of spread is very interesting. Amoebic goes along the portal vein, the portal route from the colon, and it goes more to the right side because the right lobe is larger, and also there is a theoretical advantage of right being a little straighter than the left drainage. So it is more likely along the portal vein to go to the right side. Like I said, most probably, which I personally think could be an important part, is that right lobe is larger. Its probability of getting the problem are more. This, instead of portal spread, is either systemic, that is, it comes from some other place, or it is metastatic, or it is an ascending cholangitis, which means it goes along the biliary tract. So it is more likely to be multiple on that account because you have them dividing finally and into the you have segments going. So you have multiple abscesses, that's pyogenic. Usually a sicker patient, usually a patient who has been immunocompromised, usually common in alcoholics. So always take that history of alcoholism in these patients. And there may be a preceding history of having some IV drug abuse also in these patients. Here it's more common in post-dysentery patients where patient has been having loose motions with mucus, amoebiasis, that is the history of intestinal amoebiasis, followed by pain in the right hypochondrium, hepatomegaly, which is tender. And there may be features to suggest that there is generally an amoebiasis. It's a solitary one, as I mentioned. Usually no jaundice, usually. Why do you have jaundice in the pyogenic liver abscess? Because when it goes along the biliary tract, it will produce cholangitis, which may produce jaundice. It's more likely here, although it can happen here also. It's not that you won't get it, commonly not seen. You may get jaundice here also, but more commonly here. The other reason is more of liver parenchyma being involved. This is the liver and you have multiple abscesses. They collect in various places. Now this is broadly how they are different. Liver abscess, which can be amoebic, pyogenic, usually solitary. Where is it more common? On the right side. Where on the right side we are talking about amoebic? On the posterior superior surface called of right lobe, because there is no peritoneum there. It is a bare area. That's why it's common here. While the pyogenic liver abscess can be multiple. Well, choledoco, cholelithiasis, cholangitis, pyelonephritis, nephrolithiasis, and importantly pregnancy. Appendicitis during pregnancy is a very special scenario. Thoracic causes like pleurisy, pneumonia, pericarditis. I don't think, and MI, as I mentioned, the inferior wall MI can produce abdominal pain. But what will be the feature here, if you can guess it? No tenderness. It's a effort pain. The same applies to these thoracic causes. Classically, you will have something in the chest on the contrary. So never miss out on examination of the chest. Now, appendicitis in pregnancy is the last thing I'll take here. It has a very significant role and a very important role in the complications that happen. So in pregnancy, what is it that has gone wrong? We are not getting into making a diagnosis of appendicitis, which is classical, pain starting in and around umbilicus and getting localized to the McBurney's point. That's what we have all learnt, and it is usually here, usually here. So these are the two sides. Starts here, goes there. I mentioned already in the previous slides, testicular pain goes the same way. So ovarian pain goes the same way because ovary is also sharing the same. So if there's torsion of ovary, referred pain will start here, but it will get localized to right iliac fossa or lower down. In scrotum, in case of torsion of testis, epidermolysis. So you should be careful about, you should be knowing about the various possibilities that you look at. Classically, appendicitis pain is here. And there are two important symptoms. Two signs. There are others also, but these are two important ones. The first one, symptom. Pain in and around umbilicus with referral to right iliac fossa. And second, anorexia. Remember, no patient with a loss of with inflammation has appetite. And two signs. Tachycardia will always be there, and tenderness. At which point, McBurney's point, which is the junction of the spinal umbilical line, lateral, the medial 2/3 and lateral 1/3, right? Although it's not constant, and you can get in especially the pre-ileal type of appendicitis, you may have no localized tenderness, you may have tenderness on DRE. That's why they say if you don't put your finger into it, you have put your foot into it. Then you have many other tests like Cope-Swas test or Rovsing sign, where you apply pressure in the left iliac fossa and you have pain in the right iliac fossa because of the conduction of gas or displacement of bowel or whatever the reason. And operator's test for the internally placed appendix. So that there are some features that you can look for. Now you also have a situation, one sign which is called Chandelier's sign in pelvic peritonitis, or an important cause of the pain in the right lower abdomen is pelvic peritonitis. So when you do a PV and you touch the cervix, the patient has excruciating pain which goes for the roof, as they say. That's a chandelier sign, pelvic peritonitis. Also a very important cause of acute abdomen. Michel-Merz, I've already discussed. Classically, you will have a history of mid-cycle pain, because that's when ovarian follicles will rupture, blood will accumulate, and you may have tenderness in right iliac fossa. And on opening up, you find it's a normal appendix, but the follicles or the ovaries ruptured. So you should be, and blood acts as an irritant, as I mentioned in the past. Blood is an irritant and produces classical features of peritonism. So you may actually confuse it. These are some of the signs and symptoms that you can look for, and by and large, rest are all clearly explanatory. Pyelonephritis, also called as honeymoon pyelitis, which may follow the ascending infections or ascending UTI in these patients. Left lower quadrant pain, it can again, left upper quadrant pain, peptic ulcer disease, perforated ulcer, gastritis, splenic abscess, rare. Others will have the similar symptoms. The dissecting aortic aneurysm is a cause, especially in the Western world, with a lot of atherosclerosis, and even in our country now we are seeing it. The thoracic causes can be more or less similar. You can have, like we mentioned for the right side, the same applies to the left side. Peptic ulcer disease, if the perforation happens, gastric perforation, if the fluid trickles down the left side, you can have those features. Dissecting aneurysm is an acute phenomenon in a patient who was otherwise under treatment for abdominal aortic aneurysm. Pyelonephritis will be similar on the right side and the left side. Pain of the stone is on the right side and the left side. Hiatal hernia, classically postprandial pain, and the moment the patient lies down, the pain is really not sitting up. Boerhaave is where there is a rupture of esophagus, especially in the lower part, due to any of the features which make it weaker, and they can produce a picture of, also in the Mallory Weiss tear, where there is a bout of post-alcoholism, bout of vomiting which lead to the tear of the lower end of esophagus, and there is hematemesis. So they will have their own characteristic features. Left lower quadrant pains will be diverticulitis. Now actually most causes on the right side would be, generally we'll be thinking about appendicitis. That's the reason. Sigmoid volvulus, I have discussed it previously, will be a classically an ascending acute abdominal pain. Would be perforated colon, UTI or small bowel obstruction, inflammatory bowel disease, nephrolithiasis, pyelonephritis, and of course the same that you had for the gynecological causes. Right lower abdomen is where most people would be focusing. All left except appendicitis, because appendix is on the right side, except in patient with a situs inversus. And in children, you may have mesenteric lymphadenitis as a very important differential diagnosis of acute appendicitis. And one must pay attention. Why is appendicitis rare in children? Well, it's not so common in children because the cause of appendicitis is mostly obstructive, we know that, and it's a block by fecalith. In children, this is a wider aperture compared to adults. So you don't hear of Appendicitis in very small children, but it can happen. This blockade is easier. This is a child, this is an adult. A very small amount can do it because it's longer but narrow. And here, we know that the most common cause is a fecalith at the base. It's more common. Meckel's diverticulitis can actually present exactly like appendicitis, but like the rule of two, seen in 2%, 2 inches long, 2 feet from ileocecal junction. And then there's another 2%, they have peptic ulcer, perforation and mucosa. We'll not get into that. So it is not something that you can ignore, and very many times when you're doing gone in for appendicectomy and you don't find any abnormal appendix, you should trace back the small gut at least 2 feet proximally to find out if there is a Meckel's diverticulum. It's like any other diverticulum, it's a true diverticulum. The true diverticulum is where we have all the layers. False diverticulum will have only one layer or two. Now this is a true diverticulum which can have peptic ulcer, peptic mucosa here, or the gastric mucosa here, which can produce peptic ulcer. It can also produce hemorrhage, a very important cause of obscure GI hemorrhage, and for that you do Meckel's scan, we know that. So that's also an important cause, and of course we'll look at the gynecological causes. That is the right lower quadrant. We went back. Now, cecal diverticulitis or Meckel's diverticulitis or diverticulitis of any kind will be responsible for this. You should be alert to this, but the question is, when should you manage it as a surgical method? That's what the decision you need to make. Mitchell Merz, I've already described the mid-cycle pain. Ovarian cyst, basically cyst anywhere. The complication formula is CHIT, that's a mnemonic. Carcinoma, hemorrhage, infection and torsion. So torsion and infection can manifest as an acute abdomen. Endometriosis, these are the features. Dyschezia, dyspareunia, PID. Usually what will you find? Pain is lower and it's bilateral tenderness. There may be discharge through the vagina also. Ectopic pregnancy is also a possibility, especially in a patient. You must take this history, and if the patient has collapsed and has been brought in a state of shock, it's highly unlikely that it's one of those causes of appendicular perforation, etc. Exclude pregnancy, and you must do the UPT in all of them, and you must take a good history. In normal pregnancy appendicitis, I'll discuss it separately. Round ligament pain is a differential diagnosis of appendicitis in pregnancy. What is the other differential? How do you make a diagnosis of appendicitis in pregnancy, and what is the risk? You see, it's understood that as the uterus expands, it will keep pushing the cecum up. So the site of pain would not be the same. So take that history of pain getting referred and loss of appetite very carefully. But very often the cause is round ligament or uterus itself or its tubes. So we need to differentiate. So tenderness may be higher than usual, and it has got a risk of perforation, very high risk of perforation in pregnancy, elderly, and importantly in children. In children, because there is no omentum, it's small omentum. What is a BIP in children is apron in adults. So omentum being short, and elderly, appendicular artery being an end artery, may have atherosclerotic changes, and general protection of omentum is poor. But in pregnancy, the risk is totally for a different reason, because the omentum becomes, it's like omentum has to cross over the uterus to block the appendix. It goes over bridge to seal the appendix. There's higher chance of perforation. So how would we make a diagnosis in pregnancy? By a shift test. You have to differentiate it from uterine pain. So you palpate the abdomen, mark the point of tenderness, tilt the patient to one side, that is to the left side, and mark the tenderness again. If it is shifted, then it's uterine. If it is not shifted, it is due to appendicitis. Because appendix won't move, the uterus would move. So shift test is a very important clinical test, and of course you'll do an ultrasound to support it, but by and large clinical judgment is what makes it easier to differentiate the two. The diagnostic dilemma is when the duration, location, onset, character, quality, severity and periodicity is taken into account. When it's a migratory pain, I'm repeating, appendicitis or ulcer perforation, etc. When there's generalized pain, it is peritonitis. Location depends on the organ and dermatome. We have discussed it. It's radiated or referred pain, subdiaphragmatic, supradiaphragmatic. That's how the radiation happens. The progressive pain represents a surgical scenario. Please understand this. That's the bottom line. Surgical scenarios, the pain is persisting. Vomiting is due to severity of pain or disease of the GIT. Now, pain before vomiting suggests a surgical condition like appendicitis. I think that's a very important point. Acute intestinal obstruction or appendicitis. If the pain appears, if there is pain preceding vomiting, you know of the Murphy's triad for acute appendicitis. So pain comes first. Vomiting precedes pain in medical conditions like bilious, non-bilious contents. I think this is an important point for you to remember. If vomiting precedes pain, it's more likely to be a medical condition. If the pain precedes vomiting, it's more likely to be a surgical condition. If the proximal small bowel versus distal and then colonic, fecal and vomiting we have discussed in intestinal obstruction. It's usually small bowel obstruction of longer duration or it's more distal. Remember, I have highlighted it earlier, no patient with a surgical abdomen ever has a normal appetite. If the patient says my appetite is improving, take that history carefully. You should think that the patient is getting better. Bowel, bladder and past history, constipation, diarrhea or recent change in bowel habits, immunosuppressed patients, cytomegalovirus, diarrhea and pain abdomen. Burning in micturition is usually suggestive of ureteric colic, not always there. You may have ureteric colic burning in micturition due to pelvic type of appendicitis also, when appendix is inflamed and it's lying next to ureter. It can produce strangury also. Obstipation is a feature of, which means that patient is not able to pass solid, liquid and gas. Menstrual history, just a repetition of what I've already spoken. Ovulatory pain, mid-cycle pain, this will bring in ectopic, etc., especially when associated with shock. Drug history, take history of steroids carefully. Past history of appendicectomy. If patient has undergone appendicectomy, it's adhesive, and we generally believe that the previous surgery should have taken care of these two problems. Then the diagnosis would change if there is a past history of these surgeries. The patient should be examined as a whole, and on physical examination, you should, especially in the general examination, don't miss out on the overall appearance. Classically, if you see faces that are flushing is there, or patient has got spide in AY, or there are features of stigmas of liver disease, patient is a known alcoholic, we are looking at a different patient. Similarly, level of hydration must be seen carefully. In a lot of patients due to with the history of typhoid fever or peritonitis, you may get what are called hypocritic faces, which are essentially dehydrated patients that are malnourished. You can also see the posture, which is very important. I've already highlighted. A patient with a colicky pain versus the one with peritonitis. Now, the patient with colicky pain is usually tossing in the bed because he's got a lot of pain. So, as he's tossing in the bed, he's trying to apply pressure because pressure relieves colicky pain. While the one with peritonitis would be lying absolutely still because movement would produce pain. So, you can make out whether the patient has got any features of peritonitis. Peritonitis is a problem in terms of early assessment. I mean, It's not, when there is gross peritonitis, you can have classical silent abdomen with guarding, rigidity or rebound tenderness. But in the initial phases, it's just that the patient would lie still, bowel would lie still. When a colicky pain, patient would be tossing around and he'll apply pressure on his tummy. Apprehensive patient lying quietly in bed, avoiding motion, has a surgical disease. Now there are certain one-liners that I'm trying to provide here that would help you in your practice of surgery and also in making a diagnosis of peritonitis. If the patient looks apprehensive, sweating with cold sweats, lying quietly in bed, avoiding motion, you're looking at a surgical problem. Tachycardia is a feature of any inflammatory disorder, and I've already mentioned about bradycardia. Bradycardia would be seen in colicky pain because of reflex stimulation of the parasympathetic system. A patient with an inflammatory phenomenon inside the abdomen, whether it's peritonitis, appendicular abscess or whatever, would be having tachycardia. The fever may not be high grade in appendicitis, although it's one of the three components of Murphy's triad, pain, vomiting, fever. But fever is not early in appendicitis, and a lot of patients with appendicitis may not have any fever at all. So if there is a patient who had no fever earlier, develops fever now, who had pain earlier, develops tenderness now, who was having no leukocytosis earlier, develops leukocytosis now, you're looking at a transformation of the patient into an inflamed patient. So you should be careful. So don't just look at fever as a factor. High grade fever with pain in the abdomen, patient may have medical causes also, look for them, and also septic cholangitis and gynecological infections. These are broad guidelines. It's not that there will be no variations, but generally speaking, when you're talking about the dilemmas in acute abdomen, look at these to help you out. I think I cannot overemphasize the statement that I've already made. Apprehensive patient lying quietly in bed, avoiding motion, has a surgical disease, and you should pay attention that patient may need surgery. Bradycardia is colicky pain, and tachycardia is a feature of inflammation. So it's either that the inflammation has got worsened or the abscess is formed, etc., etc. Now you're down to the abdomen and its palpation. You'll find tenderness, guarding, rigidity. Auscultate for bowel sounds. If this is present, this is present, this is present. Very often you are asked about guarding versus rigidity. Guarding is voluntary, while rigidity is involuntary. Important to look for this. I mentioned about chandelier sign in pelvic peritonitis, where on PV and just touching of the cervix, the patient will have excruciating pain and will go for the roof. Cullen sign is, we are all familiar with this. There is ecchymosis or bluish discoloration around umbilicus in acute pancreatitis, which has got to do with the enzyme elastase. Actually, elastase acts on elastin to produce very small pseudoaneurysms that can rupture and produce this picture. McBurney sign, we know, tenderness is the McBurney's point. Murphy sign is cholecystitis. Schwartz sign is also appendicitis. I have covered them partly because in Schwartz sign you're trying to push the Schwartz closer to appendix by hyperextension of the hip. So what do we do here? Hyperextension of the hip. So clinical signs are very important, and remember, acute abdomen is mostly diagnosed clinically. Appendicitis is a clinical diagnosis, and we should not be mucking around looking for investigations when the clinical signs are very obvious. So don't swear by an ultrasound, which has of course features. What are the ultrasound features of acute appendicitis is often asked question in the exam. Remember, this is cecum end-on view of cecum, and this is appendix usually. And I had already discussed with you that appendicitis is an obstructive disorder where there is a fecalith blocking the base of the appendix. That's why it's not so common in children, because it's a wide mouth here. Now, if we apply compression on the larger circle, that is cecum, under normal circumstances, if there is no obstruction, this would distend. So this circle would increase. So what will happen? I have compressed on it. with the probe, and this is distended. This is normal. If it doesn't happen, we think it to be suggestive of block at the base of the appendix. It goes in favor. Then there is probe tenderness. Right at the point where the appendix is, usually in the right iliac fossa. And thirdly, you have an aperistaltic loop. And finally, you may have periappendiceal collection. All these go in favor of appendicitis. What can ultrasound help you in further? In a lady, in a girl, it can show you the tubes, ovaries, ectopics, and help you make a diagnosis. Very, very important. That's in girls. It can let you know about pelvic peritonitis. It can let you know about abscesses. It can let you know of the rest of the abdomen. It can let you know about the gallbladder. It can exclude other possibilities. So ultrasound is, as we often say, it's an extension of clinical examination. And it is also called as the stethoscope of a surgeon for the same reason. So clinical examination is a very important part in making the diagnosis. So that's about the various aspects of appendicitis on ultrasound. Ultrasound can help you find out in children mesenteric adenitis, lymphadenitis. So it can help you make a diagnosis easily. Pregnancy and acute abdomen I partly covered, but acute appendicitis, which I also have partly covered, 1 in 1500 pregnancies with equal distribution in 3 trimesters. Now, a very commonly asked question, which is the safest trimester to operate? Second trimester. Which trimester you should not operate on acute appendicitis? In no trimester. You should operate in all trimesters. Don't confuse it with cholecystitis. Diagnosis is difficult and the outcome is grave. And the outcome is grave. Diagnosis is difficult because there is a gravid uterus. You can confuse it with the uterine pathology or round ligament pain, torsion of round ligament, etc., etc. I've discussed that already. So diagnosis is difficult. The outcome is grave because there can be perforation. I've already discussed why. Because the omentum may not be able to reach and cover the inflamed appendix. The clinical judgment is the key, and I would swear by shift test, very, very useful. But whenever there is a doubt, you should operate, and there is no trimester when it should not be done. There is no place for conservative or expectant treatment because this is going to be extremely, extremely dangerous. In first trimester, it can produce missed abortions. In the last trimester, premature labor. Second is the safest, but should be done. And laparoscopy is safe in appendicitis. Laparoscopic cholecystectomy, safe in pregnancy, sorry. It can be done in both situations. Investigations, ultrasound is safe, but by and large, the diagnosis is clinical. Cholecystitis is relatively rare. It's a diagnosis where you can actually do expectant treatment. It's clinical and ultrasound. Other conditions like pancreatitis, duodenal ulcer, perforations are fortunately rare in pregnancy. Intestinal obstructions can happen due to volvulus, rare but fatal. We have published a couple of cases, but they are fatal both for mother and fetus. And in both these cases, we had no choice but to go in. And it can be a serious problem. It can be a problem because you will then have, in this case, we had suppose we form a stoma. You have a stoma and pregnancy. So the abdominal wall loses its strength to retain to be ready for the labor, and to do cesarean section in a contaminated field could be dicey. But whenever it has to be done, we should stick to the point that living problem is better than a dead solution. So don't try to keep it there, and you need to do something in obstruction. Even if it's a stoma, take a consent, counsel the patient, and remember, mother fetus priorities are already known. You should treat and make the mother survive. Very, very important. And at the same time, there is a risk of anesthesia related issues also in these patients. Everything needs to be taken into account, but remember, keep the threshold for surgery low in these cases, especially appendicitis, as I mentioned, and then cholecystitis if the patient, the obstruction or acute abdomen. Cholecystitis one can wait, treat by drugs like we do for the index. We don't need to operate immediately, but if the patient has come with complications like perforation of gallbladder, etc., then you'll have to go in regardless of the risk involved. Now, a word about a very special scenario: immunocompromised states and acute abdomen. Say HIV, because AIDS patients are very prone to cytomegalovirus infection, and they can develop a peritonitis which is on the lines of primary peritonitis, but you need to treat them. On long-term steroid suppressed response, they can happen. Diabetics may have appendicitis, and we know you can have emphysematous cholecystitis in diabetics. And emphysematous cholecystitis is due to the gas-forming organisms, which becomes an emergency, and especially in ICU setting when the patient is ill. The problem here is the signs and symptoms may be masked. Perforations would happen even before you have any classical features of inflammation, because these patients don't have a response like any other patient who is immunocompetent. So it is surgical unless proved otherwise. And we'll mostly be doing surgery in these cases upfront, and take it as a surgical problem unless you have a very glaring feature to suggest that acute abdomen is due to, certainly not due to a surgical cause. Now, a word about the non-surgical causes of acute abdomen. Spontaneous bacterial peritonitis, which is also called as primary peritonitis. If you're asked to write on this, they both mean the same. Gastroenteritis, which would have obviously the features of gastroenteritis, and Clostridium difficile colitis, which is usually seen in patients with long antibiotic usage. And these can be scenarios where you may have to apply more of the medical acumen rather than surgical. Now, pseudomembranous colitis is more common in children but can happen in adults and follow antibiotic therapy. These are rare scenarios. And gastroenteritis, the patient will have the features of loose motions, vomitings, would need medical management. But barring this, back to the immunocompromised patient, you should go in for early, and the signs and symptoms are masked. I'm talking about immunosuppressed or immunocompromised individuals. Even if there is some doubt, you must take out the pathology, otherwise they cannot fight it and they will have complications sooner than their immunocompetent counterparts. One-third of patients who present with acute abdominal pain have non-specific abdominal pain and no clear diagnosis ever established. Very commonly seen in women with a dragging pain of the uterine, uterus and tubes, or subclinical PID, and very often psychosomatic. Important to exclude organic causes. Because you shouldn't end up declaring them as shammers or psychosomatic after having missed out. So you need to make a diagnosis and importantly look for some cause. But they continue to be abdominal cripples. They keep coming back with pain. And they could have many a times jejunal, jejunal-ileal, transient interceptions which get relieved on their own. So they can be actually confusing. Now a word about investigations quickly. Keep it simple and safe. That's what we follow. Or as I often say, keep it simple and stupid. Do only what is needed. Don't go out of the way. Don't start with a CT scan. Although if you read American books, especially the red book, it says CT scan is the investigation of choice for acute abdomen. One, it's not available easily. Two, most of the time the acute abdomen diagnosis is clinical. You can use them. You don't treat images. You have to treat the patient. So examine the patient carefully, take a good history, make a good clinical diagnosis, document it properly, follow up your patient properly, observe them closely, have an expectant treatment going. Most patients would be able to tell you, you would be able to read when to go in for surgery. We know that blood counts, DLC, there's a marked left shift. Get a urine examined in most of them. Serum amylase is non-specific, so don't swear by it, especially in pancreatitis. It can be raised in many conditions because amylase is produced even by salivary glands. In parotitis, in many conditions it can be raised. Must have an abdominal X-ray, erect and supine. This is naturally to rule out a perforation, to rule out an obstruction. Erect is to know the obstruction where, and supine is to know where it is. X-ray chest to exclude a thoracic cause like pleurisy or pleural effusion, etc. Ultrasound is an extension of clinical examination. Must be done in all cases. We don't need special investigations all the time, except in scenarios like intestinal obstruction, which is adhesive in most cases. You know, most of the common cause of intestinal obstruction is adhesions, and the most common cause of these adhesions is post-surgery. And which surgery is the most common cause of adhesions? Appendicectomy. And in women, gynecological causes. You can also do urograph in contrast study to see if there is the dye reaches the ascending colon, then obstruction is ruled out. But contrast enhanced CT scan has a role there. Now they ask you a question about oral versus IV contrast. You need both, and oral is usually water soluble, so there is no risk. Can we use barium? Interesting question, I suddenly remembered. In acute abdomen, whether it's a meal or enema is a contraindication. Why? Because barium may insipidate and cause obstruction and perforation and produce barium peritonitis, which has a mortality near 100%. So don't use barium. We use other investigations which can be done. The freak causes, you can see a worm here. This is a worm in the CBD which we had published. This was incidentally discovered. You can see that inside the common bile duct. This is a common phenomenon in places like Kashmir where the ascariasis is very common. Patient will give you a history of passage of worms in the past, may not also give, but it can be a one cause. And you know, when do the worms start getting into these places? Once the patient is put on some kind of a therapy or there is an increase in temperature, then they look for cooler places. So cooler places can be the hepatobiliary system or towards the pulmonary system. That's where they run. Bezoar, we've discussed it in intestinal obstruction. Bezoars can be a rare cause, they are not common, and they can be an operative surprise if the patient doesn't give you a correct history. Like in this case, this was a tailor who was swallowing the carpet threads regularly and other threads, and finally this was a bezoar that developed as Rapunzel syndrome. The tail was the Rapunzel syndrome, but in this mainly the bezoar was not actually in the stomach; it was in the small bowel, with the tail getting into the colon. It had descended, so patient had obstruction. Gastric bezoars don't produce obstruction, so this was actually an intestinal bezoar. Something like it was in the small bowel with tail into the large bowel. This is where the bezoar was. So it produces obstruction, can produce hemorrhage also. Then, of course, multiple strictures coming back as acute cases. Now, foreign bodies, again, we discussed this case in intestinal obstruction, management of, in the video on intestinal obstruction. It's a Foley's catheter which was used as a feeding tube that had gone into the distally into the small bowel and causing obstruction. But this is an interesting case which I discussed earlier. There are two causes of acute abdomen here, two entities. This was an appendicular knot, and it's an exceptionally rare 2-in-1 cause of acute abdomen. One was the knot going around the small bowel. So there was appendicitis. You can see that this appendix is not normal, and you also have obstruction. You can see that this is dilated. That's why we had published it. Obstruction and appendicitis both being there in one case can be acute abdomen, a rare scenario. You can see that appendix, almost gangrenous appendix has gone around through the mesentery and made a noose which has produced obstruction on both the sides. There you are. That's the appendix, and this is the dilated loop. This is a collapsed one. So it can produce obstruction in that case. Well, friends, before I conclude, must understand few points which I write here. Acute abdomen, normal individual, pain lasting for more than 6 hours, getting worse, is more of surgical import, treated as a surgical abdomen. Diagnosis is mostly clinical, with an extension of clinical examination ultrasound being used. Rely on biochemistry only when you've made it clinically. Don't diagnose appendicitis based on leukocytosis, which is a common phenomenon. The features of ultrasound clinical I've tried to cover, acute abdomen. And then investigate with bare minimum investigation and have a low threshold for surgery. In which cases you have a lower threshold for surgery, especially the pregnancy. Children, if they get appendicitis, which is rare, they perforate because omentum is short. Elderly and immunosuppressed have a lower threshold. They can't form a lump with the omentum and immunity being not so great. But keep a low threshold for surgery. In spite of whatever I have just discussed with you in this little time, there is so much more to acute abdomen that if I have to say that you can still be lost and you may still get operative surprises and you may still get cornered, I won't be wrong. Many times you open up for mesenteric ischemia, for intestinal obstruction you find mesenteric ischemia. You open up for perforated, for appendicitis, and I just discussed with you the perforated duodenal ulcer, the contents may trickle down along the right paracolic gutter and produce the right iliac fossa pain. So there are coaches who spend 18 hours a day coaching the perfect game. They still lose some games because the ball is oval and they can't control the bounce. The American football ball is oval and they can't control the bounce. It is not that you each time. This is the ex-coach of Minnesota Vikings, which used to be a champion team for the American football. So you can do your best, but if you follow the algorithm as we have discussed, in more than 80% cases you're likely to be correct. But to be 100% correct, you need to do it more often 80% so that you can finally make it 100%.